I am Philippe Pibarot, the editor-in-chief of the Journal of the Heart Valve Society, and welcome to this Heart Valve Society interview series. In this series, we'll connect with experts in our field to discuss fascinating topics and share valuable insights. Before we dive in, I'd like to remind that HVS membership offers a host of exciting benefits and opportunities. Be sure to visit the HVS website to learn more about how you can join and get involved and contribute. So we're also thrilled to announce that the next annual meeting of the Heart Valve Society will take place in April from 15 to 18, 2026 in Chicago, Illinois. So more information will be shared soon about the exciting program. So now it is my pleasure to introduce our guest for today's interview, Dr. Hector Michelena, who is a cardiologist, imager, echocardiographer, and professor at Rochester at the Mayo Clinic. Hector is a world-renowned expert in imaging and structural heart disease. He has made a very, very important contribution to the field, especially in bicuspid aortic valve disease and aortic regurgitation, among a few. Hector is a great friend and a person who I admire a lot. And so it's really a pleasure for me to interview him for this series. So Hector, welcome. I would like first to you to describe your clinical and research career pathway. You're originally from Venezuela, and you're now and for many years at the Mayo Clinic in the USA. So how did this happen?
Well, listen, Phil, thank you very much for the introduction. It's great to be here, not interviewing, but on the other side, and to be interviewed by you, for whom I hold tremendous admiration as well. May I even say that you have been a source of mentorship for me. So it's really an honor to be interviewed by you. So yeah, I was born and raised in Venezuela. I studied medicine in Venezuela. And the bottom line of the answer is that it's not about what you want in life, but it's about how much you want it. So I didn't come through, the golden gates into the US. Obviously, I came through a little hospital. And I'm not here at Mayo, and having had the opportunity to do some research just because of myself. It's because I've had mentorship, and I've had tremendous people by my side. Obviously, you have to work very hard, but hey, this is where I am. In terms of why bicuspid valve and why aortic regurgitation, well, listen, I was fascinated all my life with the existence of unicuspid and bicuspid and quadricuspid and all that stuff, and I also loved all the eponyms for the AR physical signs and that kind of stuff when I was studying. It turns out that I was imaging myself during fellowship, and I discovered that I had a bicuspid valve. So, when I came to Mayo, there was this research that was dead and had to be resurrected, that Maurice Serrano gave me. And I resurrected it, and it was the first paper, good paper on population-based outcomes of bicuspid aortic valve. And I just think it's a fantastic thing to do. It's super interesting, and it gets you to work with colleagues, and all that stuff. Now, regarding AR, I worked with Maurice Serrano, who has been my academic father, also, as you know, on mitral regurgitation quite a bit. And it always bothered me that mitral repair was a panacea, like surgical mitral valve repair, but surgical aortic valve repair was not, And for some reason, I ended up with this group of European surgeons who are the ones that lead the world in repair of the aortic valve, both trileaflet and bicuspid and quadricuspid and unicuspid. It turns out I've worked with them a lot side by side, and there's a paper out in European Heart Journal, like a state of the art of management, surgical management for repair only of the aortic valve, which I had the opportunity to participate with these, obviously as the imager, with these brilliant surgeons that are tremendous and are very good friends.
Excellent. So, Hector, you led this very important international task force, and I had the pleasure to be on this task force as well, on a new nomenclature and classification for congenital bicuspid valve and its orthopathy. Could you tell us why this task force and new nomenclature was so important? And can you describe the takeaways for the clinician, for the people who managed, the patient with PAV of this new nomenclature classification? Because before we had the Sievers and it was okay, but obviously not optimal. So
yeah, so yes, it would be a pleasure to go through that. And I'll go through that a little bit with just a couple of slides, because pictures, pictures paint 1,000 words. So let me just share these slides here with you. You are seeing it, right?
yes.
Yeah, so this is a slide just showing throughout the years. You can see my mouse, right?
Yes.
Yeah. So just showing throughout the years how many classifications and how many types 1, 2, 3, NEA, and then a super classification from Kang, which was very comprehensive. But there's 5 types here: 1, 2, 3, 4, 5 aorta, 0, 1, 2, 3, and so on and so forth. And then there's some people talking about the true bicuspid aortic valve. This is a true bicuspid aortic valve. So does that mean that the other ones are false? And obviously there's others that have been extremely short and tried to make it very, very simple, excessively simple. Like, for example, this last classification here in 2017. So what we wanted to do, Philippe, was, we realized all this multitude of nomenclatures, and everybody uses whatever they want, or they invent the one that they want to use when they're writing a paper. So, obviously it creates confusion in clinical practice, failure to identify prognostic phenotypes, and potentially hampers, future, systematic reviews and in international collaborations. So we wanted a common language without numbers or letters, just in English. It's plain old English that we could be as simple as possible, but not more than necessary, as Einstein says, so that we could cover diagnosis, prognosis, surgery, research. And for that, we assembled a huge group of people, including you, from all sides of life: surgeons, pediatricians, pathologists. I mean, you name it. And we published in these 4 journals at the same time the classification, and the classification is actually very simple. It classifies the bicuspid valve into a fused. Why? Because it looks fused. It looks like 2 cusps have been fused. And that makes up the most of bicuspid phenotypes, 90 to 95%. And there's 3 types: right, left, right non, and left non-cusp fusion, as you can see. There's usually 3 sinuses of Valsalva. A raphe is common, but not always present, and this is a problem with the Sievers classification, that does not recognize that sometimes there are 3 there are bicuspid valves with 3 sinuses that don't have a raphe. And usually the non-fused cusp is a little bit larger to compensate a little bit. And obviously, you can see here that, when we look at what they use to determine the risk for TAVR, meaning degree of calcification, presence of raphe, which is very important to define, obviously, and also other characteristics, they are all covered by this classification. Because you see, there's a lot of stuff we yet don't know about TAVR, nuances we don't know about TAVR and the morphology of bicuspid aortic valve. Therefore, we need a classification that covers all possible morphologies in a simple way. This classification also, for the fused types, classifies them in symmetry. You see this angle here of the non-fused cusp? Here is almost 180, so this is a symmetrical, this is, I take it back, let me say it correctly, this is symmetrical, this is asymmetrical around that area of degrees, and this is very asymmetrical, and this is very important when it comes to aortic valve repair, which is for pure aortic regurgitation, which is a true option nowadays, Now, the second type is very simple. It's called a two-sinus bicuspid aortic valve. It's much less common than the fused type. And it's called two-sinus bicuspid aortic valve because it only has 2 sinuses. There's nothing too special to remember about it. It only has 2 sinuses. And it tends to have symmetrical cusps. And it comes in 2 flavors. It comes in lateral-lateral like this, and anteroposterior. Usually it does not have raphe. That's very important. And then finally, one that has been neglected for many years and was finally stopped being neglected like in 2015 or so, which is the partial fusion of formed fruits. And we usually refer to these in patients, as you can see, that have a triangular opening of the aortic valve, like if it were trileaflet. But in reality, and there's no doming. You see, this is a right-left fusion without doming. Why? Because there's only a little bit that's fused. You see, less than 50% of the commissure is fused. You see, so it's what Arturo Evangelista calls a mini raphe. So that exists. It's difficult to diagnose by TTE. It's easier to diagnose intraoperatively. And therefore, we came to an important conclusion that there was a spectrum of BAV from what looks almost tricuspid, which is the partial fusion, the form fruits, going through the fused phenotypes, very asymmetric, going to symmetric, then losing the raphe, and then jumping into the almost perfect bicuspidity, which is the 2 sinus bicuspid aortic valve. And therefore, we proposed, and we have data now, unpublished, showing that there's a clinical correlate to this anatomical spectrum of bicuspid aortic valve. Now, another limitation of the Sears classification is that it doesn't talk about the morphology of the aorta, and that is very important. And 70% of bicuspid patients present the ascending phenotype, which is dilatation above the sinotubular junction, above the coronaries. 20% present the root phenotype approximately, and there are extended phenotypes, usually root ascending or ascending arch. And that's what this classification is about.
Excellent. This is, I would say this is a tour de force. This is not plain English, obviously, like Form First, but which is French, but this has been really a tour de force. I know you spent a lot of time and energy and bringing all the discipline together and getting a consensus. But I think this classification is more clinically useful for the people who manage a patient, and both for the majors, the people who do the diagnosis, refer the patient, and for the cardiac surgeons. The Sievers is not really very well adapted to guide the surgeon when he's doing a repair, whereas this one is really taking into account all the factors that
let
yeah,
me add that the Sievers classification is 012, and the number 2 stands for 2 raphes, which by definition is not a bicuspid aortic valve; it's a unicuspid aortic valve.
right.
So,
Absolutely.
so we were not in agreement with that, and we wanted a classification purely for bicuspid valve. Yeah.
Oh, that's great. So, could you describe what is your practical approach to follow and manage patient with bicuspid valve? Let's say you have a young patient who has been discovered with a bicuspid valve and no, not yet any aortic stenosis or regurgitation or orthopathy. Is there any subset of patients that you consider at high risk and you want to follow more closely and they say, oh, this one, watch out. We have to see this patient more frequently. And are there any subset of patients that you're going to be a bit more aggressive with treatment? So what
Yeah.
is your algorithm?
Yeah, and just because pictures are super pretty, again, you can see my slides, right?
Yeah.
Yeah. So let me show you this slide. This is a slide we made for Catherine Otto's book, companionship to Brownwald, for valvular heart disease on bicuspid aortic valve. And basically, what I would tell the general clinicians is that when you get a patient with bicuspid aortic valve, number one is to explore personal and family history. So personal history in terms of coarctation, for example, coarctation puts the patient at risk for further aortic complications in their life, having had coarctation, especially if it was severe, especially if it was operated upon. Having hypertension is an important thing, because if you have uncontrolled hypertension and you have aortopathy, you might be in trouble. Dental hygiene, I cannot emphasize enough, Phil, because what research has shown, I'm going to say it now, what research has shown is that we did a lifetime follow-up almost of a population-based cohort, which is published in 2023 in the European Heart Journal. Okay, first author is Yang, and I'm the last author, where we show that the lifetime cumulative incidence of aortic dissection is about 1.6% from birth to 90 years old. Huh? The cumulative incidence of endocarditis, which has been reported across multiple studies and cohorts to be 2%, which is more than 10 to 20 times the incidence of the general population of endocarditis. When we looked at the lifetime incidence, cumulative from birth to 90 years old, it was 6%. That is 4 times more than aortic dissection, and perhaps as deadly as aortic dissection. So we are forgetting about endocarditis in these patients. We have recent research that is not published yet showing that there might be some delay in the referral of these patients patients with endocarditis to care, because they are usually the most common infective organism for them is streptococci. And streptococci is responsible for the typical subacute bacterial endocarditis, which presents, with some fever, some weight loss, some night sweats, nothing dramatic. You see, so these people are diagnosed with all kinds of stuff before they're finally diagnosed. And then when they're finally diagnosed, they have an abscess. So this is also proven in the literature. So this is a big deal, assessment of dental hygiene, and not only dental hygiene, which means brushing, flossing, and dental cleanings every 6 months, but also skin hygiene. I never forget seeing a patient who came with a toenail infection, and the staph that was in the toenail, which was untreated for weeks, was in his bicuspid aortic valve. So this is very, very important. Assessment of cardiac risk factors is important. family history of bicuspid aortic valve, family history of surgery for valvulopathy. Because your children, if you have bicuspid and you had AS, your children will tend to have AS. If you have bicuspid and have aortopathy, dilatation of the aorta, your children, if they have bicuspid, will tend to have dilatation of the aorta. Very important history of aortic dissection and history of sudden cardiac death unexplained in these patients. Because you have to remember that bicuspid aortic valve also accompanies other bad players, including thoracic dilation disease and thoracic aortic dissection disease. Also, it can accompany syndromes that are associated with worse risk of dissection, such as Turner's, Loeys-Dietz, and even Marfan syndrome. Okay. Then you have to put the patient in a prognostic group. And there are two prognostic groups. There's a typical valvuloaortopathy, which thankfully is the most common, and then the complex one. And I'll show you what the difference is. And then you have to look, obviously, at the valvuloaortopathy itself. That means echocardiography. TTE is the first line of defense that we have there. And we need to establish what the phenotype is of the bicuspid valve, what the phenotype of the aorta is. If you only have mild valvuloaortopathy, which means this, well, imaging surveillance every 1 to 2 years. If you have clinically significant valvuloaortopathy, which is more or equal to moderate valvulopathy and aortopathy 45 and beyond millimeters of any segment of the ascending aorta, then that imaging surveillance is yearly, or if there are change in symptoms. There are universal recommendations to manage these patients. Number one, it is considered, although not proven yet, beyond reasonable doubt, to be of tremendous clinical use, but it's recommended in guidelines to screen the first-degree relatives of patients with bicuspid aortic valve, especially those that have complications, screening them with echocardiography. Education on the clinical course according to the prognosis group. Avoidance of isometric exercise, meaning becoming a weightlifter that strains all the time if you have aortopathy. And obviously, as I said before, prevention of endocarditis education. But when we talk about these prognostic ones, I just want to tell you that there are two major groups in bicuspid valve. There's a typical valvuloaortopathy group, which is the more common, more than 80% of what we see. Typical young adult diagnosed with bicuspid aortic valve. And it's a progressive valvuloaortopathy that lasts a lifetime and maybe accompanied by a couple of little things, okay, which are not a big deal. Now, the complex valvuloaortopathy is a different story. It is cases where sometimes the bicuspid aortic valve is almost an innocent bystander, okay? Because these people either have severe coarctation or have severe valvular disease before age 30 or severe aortopathy at very young age, associated genetic syndromes, as I mentioned, or associated complex congenital heart disease, which is what's going to lead the treatment and diagnosis, and not the bicuspid valve initially, okay? And of course, there's undiagnosed bicuspid aortic valve, which you discover incidentally. But let me give you two beautiful examples here. So this is a typical valvuloaortopathy, 60-year-old male with moderate to severe AS, right non-fusion, as you can see. Yep, is it right non-fusion? Yeah, it's right and non-fusion. This is a transthoracic echo. A root of 42, just minimally dilated, and mostly dilation of the ascending, which is the most common. And the patient is asymptomatic. This is a typical presentation. Now, look at this other case on the other side here. This is a 24-year-old male, 24, with bicuspid aortic valve, who's presenting with kind of significant AR and a root of 48 already, but an ascending aorta, which is almost normal. Now, why is this important? Well, this is important, and let me show you why. We actually published this case. This boy came to the ER because he had chest pain and had a triple rule out CT, where it was found that he had that aneurysm of the root. And he was sent to valve clinic to see me. But before the valve clinic, he came again to the ER with blurred vision and underwent evaluation and was found to have an intracranial aneurysm. So I even saw this guy. I sent him for genetics. And this guy, who had a completely normal physical exam, Phil, had the Lois Dietz 1 mutation, which is characterized in 50% of cases by having nothing physically. And in 10%, they have bicuspid aortic valve. So you can see what a complex one is and what a simple one is. And therefore, we concluded, obviously, that genetic testing counseling in BAV and more attention if you see syndromic features, if you see multiple systemic features, if you see complex congenital lesions, family history of early dissection or sudden cardiac death, aneurysms or dissections of medium-sized arteries other than the thoracic aorta, as we saw with this boy, and basically young patients with accelerated valvular aortopathy, meaning less than 30-year-old with accelerated valvular aortopathy, particularly root phenotypes and aortic regurgitation, we believe should be looked up a little closer.
Excellent. I love your algorithm, and I love the figure that you show that you have in the brown valve chapter. It's great. I think it's very useful for the clinician, and I think important takeaway is to me, and this paper you did with Young is the underestimation of the risk of endocarditis. Historically, in bicuspid valve, we have always said, well, pay attention to the risk of aneurysm and dissection, and maybe we have overestimated the risk with dissection, as you showed in your papers. But on the other hand, I think we almost completely missed the risk of endocarditis, and I think this is the greatest threat actually for those patients. And endocarditis is such a bad disease, So I think your message of importance of dental care and is really key. And I think this is something that the people who are attending this interview should keep in mind. One thing that has kind of frustrated me, with this patient with bicuspid valve disease, it is very difficult, and maybe you have some clues for us to predict if you have a patient in front of you with bicuspid valve, not yet any valvulopathy or aortopathy. Who is the patient who's going to progress rapidly to valvulopathy, aortopathy? Which type of valvulopathy? How can we predict, for example, the patient who's going to rapidly develop AS and need aortic valve replacement within a lifetime versus the one that eventually will develop a life-threatening aortopathy versus many of them who actually remain stable and never develop anything, to me. So is the answer in the genetics, in the imaging, in nothing?
I'll tell you a couple of things. So it's a valvular aortopathy. So there's two things you have to be aware of development of AS and AR and development of dilatation of the aorta, which is the expression of this aortopathy. So in these cases, family history is critical, as we said. If you have a family history of your dad had a bicuspid valve and he dissected at age 50, that's a very big deal. Okay, and that means that we're going to follow that aorta of yours very close, and that we're going to operate at the lower level that is indicated. Okay, now in terms of progression of valvulopathy, general risk factors, and I'm sure you can comment on this also, Phil. General risk factors such as diabetes, hyperlipidemia, lipoprotein A, are involved in progression and genesis of aortic stenosis. And in my mind, are clear. I mean, we have shown, I'll show you some slides, where we have shown, particularly for patients less than 60 years old, that those risk factors are a prognostic of development of aortic stenosis. The other thing that's obviously critically important to know is that the most common valvulopathy that these patients develop is aortic stenosis by far. Okay, and that it's expected that about 80% of them to 90% in their lifetime will develop some degree of aortic stenosis. Okay, a couple of other things. The right non-fusion phenotype tends to progress faster in children and adults with AS and AR. Okay, when you see left ventricular outflow tract dilatation in an adult, saying, meaning more than 25 millimeter LVOT, that is a patient prone to leak, especially if that is associated with some prolapse or associated with dilatation of the root. And a very important contribution from a European group on the calcified raphe. When you find a calcified raphe on a patient, the progression to aortic stenosis is very important. So these are all clues that direct you into, who you have to keep a closer eye on.
Excellent. And so I'm going to surf on this and progression. Let's say you have patient with aortic stenosis, so bicuspid AS. Do you have the perception that the patient with bicuspid progress more rapidly or less rapidly than the patient with the tricuspid valve AS? And
Yeah.
should we, in other words, I'm not talking about the younger patient or the patient with an autopathy, but if you have a patient with AS, should we follow differently the patient with bicuspid versus tricuspid because they might be at higher risk of accelerated progression or not?
Yeah, you can see my slides, right?
Yes.
Yeah, so this is a super interesting question, and you know that literature has produced various opinions. To some degree, I think because these studies are mostly retrospective, and there's some bias to them. But we published this study looking at bicuspid versus tricuspid AS. Okay, and we showed that the progression was the same between them. Okay, and we tried to correct for all possible confounders and be statistically very clean. That's what we showed. Okay, now the differences that we saw in bicuspid stenosis versus tricuspid were obviously younger age in BAV, more males in BAV with AS, larger left ventricular outflow tract, which is a good thing because you can put larger prosthesis in them, and a larger aortic valve area, somewhat to do with the fact that they have left ventricular outflow tract is larger. Therefore, for guidance on aortic valve area, you will sometimes get a bicuspid male who classifies as hemodynamically severe AS with more than 40 millimeters of mercury, more than 4 meters per second, but the aortic valve is 1, or the aortic valve is 1.1. So does that patient have severe AS or not? Well, what studies have been done, at least a couple of them, show that you should treat them as severe AS. And they probably have a little better prognosis than the typical AS with low aortic valve area. But it's been shown that they have bad prognosis if they are not operated upon. Now, a critical thing is we saw a 10-year stenosis progression rate that was the same between bicuspid and tricuspid. I think your group might have shown different, Phil. But we showed also something very important. There was a very significant reduced 12-year survival in the tricuspid. And of course, you will ask me, well, obviously, they're older, right? Well, we matched these people for age and sex and everything, and still there was a significant survival advantage for bicuspid patients, okay, which is a great thing. And we concluded, Phil, that this was the reason, okay? BAV came out to be independently protective of AS-related cardiac damage. independent of age, such that bicuspid aortic valve was more affecting more patients that were young and at lower risk in general. So if you look at the cardiac damage profile of a patient with tricuspid aortic valve AS, you can see that all these things, volume index, bad ejection fraction, pulmonary hypertension, TR-MR, atrial fibrillation, are much higher than patients with aortic stenosis who have bicuspid aortic valve. And therefore, we thought that the tricuspid aortic valve has a total burden that not only includes the hemodynamic burden of AS, but the burden of comorbidities and the burden of high cardiac damage, versus bicuspid aortic valve, which probably represents more just the burden of the valvular disease itself, you know? And I'll tell you something, we found that modifiable cardiac risk factors were associated with rapid progression in bicuspid aortic valve. Not only that, I did a study with the Mexican colleagues showing that diabetes, particularly Mexicans, was associated with progression of AS in bicuspid patients.
Which makes sense. Yeah, no, excellent, Hector. And so we have covered the progression. So we are now, at the time of intervention, and the European guidelines just were released this morning. The 2025 European guidelines for the management of valvular disease, and they included a new indication for TAVR in bicuspid valve in patients who are at a high risk of surgery. So it's not what they say increased risk and favorable anatomy. And it's a 2B indication. So kind of, not strong, but it is there. And so I want to have your opinion. What is the role and maybe the limitation also of TAVR in bicuspid valve? And a kind of a follow-up question. Do we need a trial of TAVR versus SAVR in bicuspid valve?
Yeah. So the short answer to those two questions is, what is the role of TAVR in BAV? Is that it's currently limited and it should be reserved for older patients who are at high risk for surgery and have a good anatomy for putting the TAVR on. I mean, that's as simple as that. And I think that probably that indication in patients over 70 years old to be with appropriate anatomy is not bad. It's not bad.
Yeah.
And do we need a trial of TAVR versus SAVR in bicuspid aortic valve? Absolutely, yes. And let me just show you this really quick. Let me share this, and let me share, because our readers may be interested in looking at this. This is an editorial we recently wrote, just very recently, for circulation interventions. You see, what's happening is physicians and industry and patients are all pushing for TAVR. Why? Because it's easier, because it has less risk. It's human nature, okay? Now, let me give you a recent example of a dear patient of mine who's 83 years old, had a bioprosthetic aortic valve in the aortic position surgically 11 years ago, which was degenerating. And we put a TAVR in valve, TAVR, right? And the result was super good, okay? He comes back in a month and it's thrombosed. Now I have to start the 83-year-old guy on Coumadin to unthrombose this thing, okay? He came back with a gradient of like 42 through the TAVR, okay? So that has to bother your mind in terms of taking a young patient, 55 to 60-year-old, which can come with severe AS and bicuspid aortic valve, and doing this to them, okay? Particularly knowing that there's no clinical data on redo TAVR for bicuspid aortic valve, redo TAVR, okay? Also, these patients have incidents of aortopathy and dilatation of the aorta. What are you going to do for that? You know? So what you're setting this young patient up for is for a failure of a TAVR, going for surgery, which you and I both know that literature out there on open surgery after TAVR for aortic valve replacement is high risk.
Yeah, I agree.
So things should be the other way around, Phil. We should do the high risk stuff first. So the Ross procedure first, the aortic valve primary repair of AR first, the SAVR first, and decide between mechanical, and then reserve TAVR for the second or third stage. Okay.
Yeah, I agree.
Yeah, and let me tell you something that I just highlighted here. So just about, there are two important studies out there on this. One is the Notion 2 study that only included 49 patients bicuspids randomized to SAVR versus TAVR, and their findings were quite worrisome because they found a 6% 1-year death disabling stroke in TAVR, in bicuspid aortic valve, versus 2% in SAVR. And this is a recent randomized study. It's the only randomized data that there is. Now, you obviously can criticize the Notion 2 trial because, there were questions raised on the type of TAVR devices, on the type of bicuspid phenotypes, and the study was underpowered. Okay, but that's what we have. Now, on the other hand, we have a US-based study, okay, reporting on 3,000 propensity-matched bicuspid versus tricuspid patients showing the same mortality and same stroke 30 days after TAVR and 1 year after TAVR. So which one is it? And there's the answer. We're arriving at some kind of equipoise, and we need to decide, what we're going to do with TAVR and bicuspid aortic valve. And I think a trial of SAVR versus TAVR is obviously needed.
Yeah, I agree. And there are actually two large trials on the map: the Navigate trial and the Believers trial. And that should be initiated soon. So this is coming. And I think if we summarize, I think, TAVI, yes, maybe has a role. I agree, limited for bicuspid valve if the patient is at high risk for surgery first, and favorable anatomy. And the favorable anatomy is maybe not what we anticipated initially. I think clearly the partial fusion, the form first, is not a problem. The two sinus BAV that we were initially thinking, oh my God, TAVI is not good. Well, actually, they have very good outcome with TAVR. And the one that maybe are more higher risk are the fused BAV. Especially if there is no raphe, that's not a problem. But if you have fused BAV with calcified raphe, this is where it's maybe not as good.
All of that is true, but it's even more complex than that. The study we wrote that editorial for showed very interesting findings. Showed that in patients with two sinus who had a particularly calcified leaflet, the TAVR was misplaced.
Yeah, as soon as you have asymmetric calcification, then this is where you're in trouble.
Yes, was asymmetric. They also show something critical, Phil. Current CT-based virtual analysis protocols to predict the result of index TAVR in bicuspid AS are unpredictable. They are not like tricuspid aortic valve. They are unpredictable. So there are many nuances of these valves that we don't know, such that the big people that are into prediction of TAVR are going to AI.
Mm-hmm. Yeah, I agree.
What's worked here.
Hector, time flies, and I think we could have talked for forever on this topic. I think we need a second interview with you, especially to talk about AR. But my last question would be, what do you think is the next topic in valvular disease we should work on, both on the research and clinical front? What is what should be our next mission and mandate in the field?
Yeah. And listen, by the way, I am pro TAVR and I am pro technology and I am pro patient safety, but we have to be careful.
I
Um,
agree.
um, so listen, I think that there's a lot to do still in bicuspid aortic valve genetics and TAVR and I mean you name it. That being said, as you and I have spoken many times before, I think it is a failure of society and a failure of the medical community as a whole and of us as cardiologists as a whole to see that worldwide, the most common valvular heart disease is rheumatic heart disease, and young people are dying from this. Well, we're putting new technology on 95-year-old patients in the Western countries, and I'm not blaming the 95-year-old patients. I'm just saying that we need to look at what's important in life and in the world. And I think that you and the World Heart Federation, Jagat Narula, and I, to the best of my ability, have been working on trying to bring this topic of rheumatic heart disease to out to the light.
Excellent. Thank you so much, Hector. This was fantastic. It's always a pleasure, chatting, more brainstorming with you. And so thank you to the audience for joining us for this HVS interview series with Hector Michelena. We hope you found the discussion as engaging and informative as I did, at least. So stay tuned for more interviews in this series, and we look forward to connecting with you again soon. So thank you so much, and stay tuned. And also, given that I am the editor chief of the Journal of Valve Society, I strongly encourage you to submit your research, your ideas, your viewpoints to the journal. Thank you so much.